PCOS is so grossly overdiagnosed. So in practice, anytime I see somebody who's like, I have PCOS, I'm like, we're going to gently operate under the premise that's not true until proven true.
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast. Hello, everyone, and welcome back to the Advanced Women's Health Podcast. I am here with Dr. Michelle today, and we are so excited to talk about how to manage PCOS in your 30s, because this is a conversation we have in our offices literally every day. And it's such an important one because all the time we hear like, why the hell do I still have acne? Why are my periods irregular? Why don't I feel like myself? Why am I gaining weight when I feel like I shouldn't be? Why did the stuff in my 20s work and now it doesn't work? What the hell is going to happen if I decide I want to get pregnant? Does this mean I'm infertile? What does this mean? And so we really wanted to bring these conversations to the forefront. We wanted to give the opportunity to just have a really real talk chat about what it means to manage PCOS, what is PCOS, and it doesn't really matter what your goals are. When you manage the underlying causes of PCOS, everything gets better. Energy, fertility, hormonal health, acne, regularity of your cycle, all of those things improve. So why don't we just jump right in and give us an overview of what PCOS is, how someone might get that diagnosis, and what the underlying components are that cause this condition.
Yeah, for sure. So PCOS is so grossly overdiagnosed. So in practice, anytime I see somebody who's like, I have PCOS, I'm like, we're going to gently operate under the premise that's not true until proven true, because ultimately what we're really looking at is seeing two of the three following symptoms. So seeing irregular or absent cycles, and that means cycles that are more than 35 days. It means seeing high androgens. So on blood work, that looks like high DHEA, high testosterone, but clinically it looks like acne. It looks like dark thick hairs on the face, the nipples, the abdomen. It looks like male pattern hair loss. And then cysts on the ovaries. And cysts on the ovaries, we're seeing that on ultrasound, but it's a very specific type of looking cyst. So when people come in and they're like, well, I have a cyst, I'm like, well, that could mean you ovulated. Like that doesn't mean a darn thing. So it's a very specific presentation of a type of cyst. And then there's a cool new, fourth layer to this, especially if you're in the fertility world, having a high AMH, a high anti-Müllerian hormone. It's something that comes from developing follicles. So again, if we have lots of cysts on the ovaries that we can have a high AMH, that can take its place. So you need to see two of those three things. And so if we see two of those three things, you have PCOS for the most part. Again, there are some caveats and some extra rules to that. And we talk about that kind of clinically all the time, but that's PCOS in a teeny tiny nutshell. And so in terms of getting that diagnosed, we need to have blood work done. We need to have a history done, and we need to have an ultrasound done just so that we can really appreciate the lay of the land and getting all of that appreciation there. In terms of the things that are really contributing and driving PCOS and its dysfunction, a couple of things just to piggyback off of what you spoke about, that when PCOS is managed, it doesn't look like you have PCOS. You just look like a normal cycling person. But in terms of the things that contribute to that having existed in the first place, we're really looking at insulin and insulin resistance. We're looking at inflammation and that causing dysfunction. And so those are two of the big things. But what really happens with PCOS, to break it down, because I think that appreciating what the condition actually is that we have an environment around the ovaries that impairs us from being able to ovulate, that drives up this hormonal dysfunction and creates symptoms in the absence of periods. And that's where the wheels kind of fall off. Again, that's the gross macro version of what's going on there.
Yeah. And let's workshop this. So we meet for an hour every day as a team. And when we're going through and someone will be like, okay, so this patient's coming in, they have an irregular period and they have acne. As the evil owner and clinical director, I'm like, okay, let's run all of the possible causes for these things. So let's do that because I have been the person on the other side of these podcasts. And I'm like, okay, so if it's not PCOS, how do I know if it is? How do I know if it isn't? What questions do I ask? So let's start with some of the symptoms. So I find personally, irregular periods, hair growth, and acne are the three main reasons someone approaches a diagnosis and like goes to their doctor to get help. Would you agree with that?
I would agree. I would say that the only additional is people who are trying to conceive get like thrown that diagnosis all the time additionally. But outside of the trying to conceive PCS, it's exactly what you just mentioned.
Okay. So then let's look at anovulation. What are the potential things that you think about when someone is not by anovulation? We mean that someone hasn't thrown an egg out of their ovary on day 14 to 18, 12 to 18, depending on who you are every month. So you're not having a regular cycle between 28 and 35 days. There is some belief, I disagree with it, that if your period is up to 40 days, right, then if it's up to 40 days, you probably could have ovulated. If it's over 40 days, you probably didn't ovulate. I don't subscribe to that necessarily, but in any case, you have very irregular cycles. What are the causes of someone having missing 2 months of a period and then they come back and they get two in a row and then they miss six? What are some of the potential causes there?
Related to PCOS or outside of PCOS?
Just our DDX list. That's what we
Yeah,
call
our
it. Our
DDX, yeah.
differential diagnosis.
Yeah.
This is clinical round style today.
So whenever we see a cycle that's missing, PCOS is obviously one of the things that's coming up on our radar, but alternatives to that are things like hypothalamic amenorrhea, which is just fancy terms for stress-induced absence of a period. So that can be emotional stress where the body doesn't deem it safe enough to ovulate and to procreate, and therefore we're just going to halt that situation. Also, under eating can be one of the sources of stress because if your body doesn't deem that you have enough fat again to procreate, then we're just not going to do that. We're not going to throw an egg. We're not going to give the opportunity for that. So those are two of the biggest reasons I would say, along with the PCOS. Granted,
I just giggle. You can tell we do this all day when we're like, you just throw an egg. You know what I mean? Like my chickens in the backyard, just like whipping it up.
oh, the silky chickens. Oh my goodness. But yeah, so I'm following your lead on that one. I'm like, ovulation is the main event of a cycle. And I think people get really hung up on the bleed being the main event, but you can have a bleed where you didn't ovulate and that can still be dysfunctional. And so that's something that can happen. You can still have PCOS and like be bleeding with some degree of regularity and it still be dysfunctional and still feel quite crummy. And there can be other reasons why that happens too. But nonetheless, that ovulation is the main event. That's the piece that matters most. And once you ovulate, you are either getting pregnant within a 12 to 24 hour period of time, or we are bleeding, 15, 16, 17 days at most thereafter. But that a bleed is inevitable once that has happened if you haven't gotten pregnant. And so ovulation is the big piece here because with PCOS, if we're not ovulating, that's the cause for concern essentially that we're dealing with and that we're managing.
Yeah. So we've got hypothalamic amenorrhea. So that's one of our DDXs, meaning under eating, there's a stress response. Even within that, so I talk about this a lot. When I went through puberty, I was obese. And so my brain set point for adequate body fatness is higher than someone else's. So the average person, we say if they drop below 16 to 18% body fat, then they will stop menstruating. Right? Their body's like, we do not have enough body fat to carry a pregnancy. This is also where a lot of symptoms can come up at puberty because we become physiologically insulin resistant, meaning our body prioritizes storing fat as fuel during puberty so that you can get the body fatness to trigger you to have a period. But in my situation, my body fat percentage has to be at least 23, 24 in order for me to cycle regularly. So there's a component of how your brain perceives everything as well as what's actually happening. And that's a whole nother conversation. But if you're sitting in this camp of, I don't feel that stressed, I don't undereat, but you have experienced big fluctuations in your weight historically, you have experienced other bigger shifts in physiology, that could be one of the reasons as well.
100%. No, I'm glad that you brought that up because it's definitely a factor that comes up when we're looking at somebody not necessarily being frankly underweight, but still losing their cycles, that the brain is perceiving that to be unsafe still.
And what are some of the other DDXs? What are some of the other things you think about when it comes to that or that you want to rule out?
When it comes to like absence of a cycle. So something called premature ovarian insufficiency, which is essentially like a premature menopause of sorts. So it can be caused by a number of things. And we discuss this quite a bit in clinic, but it's essentially when the ovaries, again, have a degree of damage that's taking place that is impairing ovulation or egg quality and the ability to kind of get an egg across the finish line and to ovulate. So it's another one that comes up. And unfortunately, it's definitely something that we see that's on the rise as of late. So sometimes, again, making sure that you're getting the right diagnosis, especially in a fertility realm, but also outside of that is really key. Because at the end of the day, like ovulating, if fertility isn't a goal, is still really important because clinically, like the estrogen that you're getting from those eggs is protective for like your bone density. It's protective for your cardiovascular health. It's protective for your brain health, right? The progesterone that you're getting from ovulation is helping to calm your nervous system and plays a role there too. So like, it's one of these where even if
Your
fertility
immune system.
Yeah.
God knows I love an immune system regulation from progesterone.
So it's one of those where like it's really relevant that you cycle, even though I see a lot of women who are just like, but I'm not having a bleed. Like, I don't know if that's a problem if I'm not trying to conceive. And I'm like, still a really big problem. Like, still matters to your long-term health. May not matter now, definitely going to matter down the line and get kind of the second half of life that we're looking at and making sure that's a healthy second half.
Totally. So then when it comes to acne, what are some of the underlying pieces of acne? And I will pull our skin docs on here at some point to go deep into this, but just super high level. What are some of the things you think about when it comes to acne?
Yeah. So when it comes to acne, insulin is a growth hormone. And so to get a little nerdy for just half a second, bear with me. The bacteria that feeds on sebum, which creates acne, that insulin, again, being a growth factor, it's going to drive up basically the food that feeds the bacteria that contributes to acne. And so that's one of the mechanisms in which insulin will contribute to acne development. The other is through an I'll ditch the enzymes. I'm like, I'm going way too nerdy today. I'm like, my brain's just like,
there are people listening that are like, let's nerd out, right? So Michelle's talking about sebum in that situation, right? So sebum is the oily component. That's why your skin can get very oily, your hair can get oily. If you have a lot of oily skin and a lot of oily hair and a lot of sebum production, then even if you don't have acne, that can still be a sign that your insulin is too high. But you can use the dirty, nerdy enzymes. We've got the most intelligent audience in the world, so.
Wonderful. With alpha reductase, so it's an enzyme that's basically going to convert testosterone to DHT, which is a really powerful form of testosterone, which can also contribute to acne production. So the insulin is working through two different mechanisms there, which is that it's driving up the food for the bugs. And then secondly, that we're driving up androgens, so that are also contributing to that in and of itself. We also know that inflammation is going to play a really big role when it comes to this. And when we're talking about inflammation, you can't talk inflammation and not talk gut health. Like the two go very much hand in hand. And quite frankly, you can't talk about insulin without talking about gut health, because we know that 40 to 60% of the body's insulin signaling is determined based off of that. So if you've been like white knuckling it through trying to lose weight or control blood sugar, and you're like, you have to eat just so, but nobody has ever treated or looked at your gut, we're missing it, right? There's a big part of the equation that's being missed. And same goes for acne, that if we're not dealing with gut health, if we're not looking at insulin, we're not looking at androgens, that we're not tackling this from all of the factors in which are involved, then we're going to miss the boat. You're not going to get symptom improvement, right? So those are some really big kind of overarching ways in which we look and consider acne to make sure that we're dealing with it effectively.
And this is why it's so important. So research shows about 75% of us have insulin signaling issues. Not Michelle or myself, though. Never at any point in our lives have we had that. No.
But you know
But
what? Having watched the walk means you get to help people through it too. And so like it's actually I will wear my previous insulin resistance badge with honor because I'm like I've been in that boat and it's fixable, which is the really cool part
yeah,
is that it's not like a sentence that is irreversible. But yeah, we've both had our insulin resistance.
I had to be the awful person to tell Michelle. So, but it's so important that we have this conversation because if 75% of people have insulin resistance, and then there's a whole category of people who have also spent a bunch of their life stressed AF and under eating, the chances are pretty strong in your favor that you can have acne, androgenic symptoms, and an irregular cycle at one point in your life. So I wanted to run that list because I think it is so important. Like if you had an irregular cycle in the past and your doctor doesn't ask, well, were you under eating at that time? Were you really stressed at that time? You go in and you say, I have acne and I want to try to conceive, for example, right? And you're saying, what can I do about my acne? I want to try to conceive. I'm worried about what topical products I can put on. I'm nervous about it, right? And they say, oh, well, have you ever had an irregular cycle? And you're like, yeah, I did. And they're like, oh, well, you have PCOS then. It's going to be hard for you to conceive. If that is the conversation that happens, and it does happen a lot. And I'm not judging anyone for that conversation. I'm not saying it's not well intended. But the reality is, if you have a 7-minute appointment and that's as far as you get, then you are going to leave there devastated. I was that person. I didn't have a period for 6 years, right? Almost 6 years. And they were like, oh, no, you have PCOS.
And the thing
I'm
is like,
sorry.
it's so wrong because at the end of the day, they have such like differing treatments. And
Yep.
that like it just perpetuates that you don't get well, right? Because I'm like, if you have PCOS, we look at that wildly different that we do hypothalamic amenorrhea for many aspects in terms of like, do we need to lose weight? Do we need to put weight on? And like, that's just one teeny tiny component of it. It goes well beyond that. It's really looking at the insulin piece, but nonetheless, that like they're
Yeah.
different. And so like the diagnosis is so crucial so that you actually get the appropriate treatment. So you actually get where you need to be.
Yeah, and there's 4 big categories of PCOS, right? Like there's the typical category that we think of, which is where someone has extremely high insulin. They have high male sex hormones. They have acne, they have hair growth, they have hair loss, they have weight loss resistance. Like they've got all the patterns. They've got a very irregular cycle. Like it's what we'd call like a severe presentation, right? Then we have people who are ovulatory PCOS. I didn't used to question this. I question this more now, where they have the string of pearls. So they have a whole bunch of little tiny follicles trying to develop. They have a kind of irregular cycle, but they are still ovulating most of the time, but they have androgenic presentations, right? The further we get down the line, the less and less it looks like PCOS, which is why in our offices, we are using testing as the tiebreaker, right? We are saying, okay, cool. I understand you've been given a diagnosis, as you said. Let's just like hold that respectfully in question for a hot second. And then we do other investigations to give people accurate and effective information and diagnosis. So why don't you run for us what some of that testing looks like and what, if you had to pick 3 or 4 tests, what would be the most critical ones that would give you the answers you're looking for?
You already know the first, which is going to be the insulin glucose challenge is a really awesome test. So if anybody has listened to this podcast for any period of time, they have heard of this. But for those of you who are new and haven't heard of this, the insulin glucose challenge is essentially a test where you go into the lab fasted. They measure your blood sugar and your insulin at fasting. You drink a beverage that contains 75 grams of glucose and then retest at 30 minutes, 60 minutes, and 2 hours to see exactly how your body responds to that challenge, both in terms of glucose, but even more so in this situation in terms of insulin and just seeing how much insulin are we producing. Is that an unreasonably high amount? Because again, we know that's going to drive a lot of these symptoms. So the insulin glucose challenge, really helpful. Knowing what blood sugar on average is, HbA1c can be really helpful. going to group my labs together because I'm like, I can't pick just a couple. I'm like, we cherry pick when we're in appointments and we can, but I'm like, this podcast, we can do what we want. And so the other being something
But
called,
I think it is important to acknowledge, like, we can run every test in the world if we want to, but there are going to be those key ones that are going to give you information. AKA Sarah
100%.
gets her way all.
And so the insulin glucose, I would say, is one of the most important of those. Inevitably, free fatty acids can also be helpful just to give us an idea of how much metabolic dysfunction is kind of at play and how much insulin resistance. Because again, sometimes we see labs they sit on the fence. And so sometimes when you can stack some of these metabolic lab tests with each other, you're like, this one tells one story, that one tells another, and this one really corroborates, a tiebreaker. So anyways, those are some of our metabolic kind of factors. As far as androgens go, there are the male sex hormones. It's things like testosterone and DHEA are really helpful when money grows on trees. And I would say that this isn't one that I have had to do, that like a DHT can be helpful, but like there are lots of different androgens that we can look at, but we can look at some basic ones and just kind of get an appreciation for the lay of the land. And then in terms of others, really cheap, really easy inflammatory markers, ESR, CRP, and they give us a good idea of what's going on from an inflammation perspective. Anybody who's in the fertility world, that there's the AMH that I had mentioned earlier, which is a blood test that just gives us an idea of how much hormone your ovaries are producing from follicles. And so in the case of like a POI, a premature ovarian insufficiency, like that premature menopause that we were talking about earlier, and that being a cause for absent cycles, and this, like an AMH can be helpful in some of those situations to appreciate what's going on. And for anybody who's getting pituitary hormone, so things like FSH and LH tested, make sure that you're doing those on a cycle day 3 or after kind of like a progesterone challenge so that we're getting some accuracy to those. Because if you're doing those kind of at random, we can get really varying numbers. And so we want to make sure that we're interpreting any of those appropriately. Because I get a lot of people who are coming in who are confused. They're like, my medical doctor didn't tell me to go at a specific time, no shade to them. And now, like, I don't know what these mean. And depending on where you're reading those within a cycle, like the numbers need to be very different within that. And some are going to be, anyways. So just making sure that we're interpreting those correctly, I think is also key. But those are some of my favorite labs, I would say.
And cycle day 3 is 3 days after full flow. To be clear, I have patients all the time that will spot before their cycles, which is a whole nother conversation. But within that, they will go 3 days after they start spotting. It's 3 days after flow, like flow of bright red blood. So that's an important thing to bring into context as well.
Yeah, thank you for making that distinguishment because it's true. Cycle day 1 is just, it has to be when real flow is happening. If it's not a spot, that doesn't count. And if we're just spotting again, we probably aren't having a cycle. Like if there is no real day of bleed, like it's again, another conversation.
Yeah, absolutely. So I'm going to throw us for a little bit of a loop here because I don't hear this talked about enough, but what about lean type PCOS? So we talked about in typical PCOS, there's very high insulin. That high insulin is causing high levels of androgens. Those high testosterone is inhibiting ovulation, creating more and more follicles developing. That's the typical presentation there. But what about lean type PCOS? How do you know if you meet those criteria or not within that context? It's something we're having this conversation a lot more. So walk me through what your thought process goes through there.
Yeah, with lean type PCOS, clinically, the first couple times you see it, you're just like, what is this? Because it looks like a duck and it quacks like a duck, but it's not quite a duck and you're confused. Anyways, my analogies are awful. Sarah's giving me the eyes. But that...
No, like, no. So if anyone wants to know Michelle will be like, it walks like a duck and it quacks like a duck, but it's a horse. You know what I mean? Like, it doesn't make any sense. She is from Sudbury, so we give her a lot of grace around that. For all of my Sudbury listeners, I have been there, and Cotton Eye Joe came right on my Spotify as soon as I crossed that line. There are facts about that city. And your analogies are one of the really great representations of the culture there. No, I'm joking.
No offense to Sudburians. I'm like, I love you guys. With reeling us into the lean type PCOS again. That with lean type PCOS, essentially what can be happening is that despite the fact that we have normal circulating or even low levels of circulating insulin, that you can have locally to like local at the skin, local at the ovary, high levels that are happening there. Again, because of that enzyme that we were talking about, the alpha reductase, that we can have an increase in that activity that's happening locally. And so systemically, it looks like one thing, but locally is a whole other story. And so in those situations, I find like an AMH still going to be high, right? And so despite the fact, and like we'll still see the cysts on the ovaries, we may or may not see the high androgens, we may or may not see the insulin. We tend to see one or the other. But that nonetheless, that's what I mean about the duck piece, is that it's like all of the endpoints are still the same. But when you're doing the labs, it doesn't necessarily track. And so it's not as classic, it's not as in your face, but it's still very much at play. But it's just because it's happening locally at the skin, at the ovary.
And the glucose almost always does something wonky on those tests, right? So the person will either have very high glucose and you're like, okay, you are borderline pre-diabetic here, even though you're lean, or someone will have hypoglycemia in like when they drink that drink, their blood sugar will go up and then boom, hits the floor at the end. If your blood sugar stays low the whole time, we talk about that in a different way at the clinic. We can probably get into that at some point, but there's almost always some kind of weird glucose stuff happening that's telling us that insulin is signaling in a weird way in the local tissue area, for sure.
Yeah. And so it still becomes one of these where managing that is still key to seeing a change. It means that the treatments do differ is ultimately my big message there, that there's still treatment to be had, that we still want to manage what's going on locally in those areas, but that the approach is different between the different types. So again, getting the diagnosis right in the first place, and then figuring out where you kind of fall in that cascade of types of PCOS, so that you're getting the most appropriate and relevant treatment to manage that.
You just need to gain weight and go from there. And that can make symptoms even worse. But we both had events over the weekend. And one of the things I think I said most is if you feel like something's off, it probably is. And whether that is, and someone said to me, well, I'm just a hypochondriac, like I have a ton of anxiety. And I said, okay, cool, that's still a symptom. That means there's something off with your anxiety that we could manage. Right. And so you deserve to get the results that you're after. None of the tests we've talked about are $1,000 tests, right? Like most people, it's very much within their budget. It's very much, oftentimes insurance even covers it, right? Like it's very much within their realm of possibility in terms of what they can access. And so I just really want to reinforce that. If you want more answers, ask for them. You do not have to go to Turkey to get medical tourism in order to get a proper investigation. Like we have these resources available. It's just not talked about as much as it should be. So yeah, but let's navigate now into, okay, how the hell do we manage PCOS in our 30s? Like where do you start? What does that conversation look like? Walk me through that as what's happening from the perspective of what's happening in your office.
Yeah. So I always tell people that like with PCOS, there are a number of supplements that can be like truly life altering and like changing from that perspective and really, really help. You didn't eat your way into PCOS, but you can eat your way out of it. And at the end of the day, it's one of the most important factors when we're talking about it. And this doesn't mean that these have to be really restrictive, really awful diets, but getting some really foundational pieces in as far as diet goes, again, can be life changing because that's really key. Making sure that we're dealing with the insulin issues that are coming from the gut, treating the gut, also going to be really key. And that's going to hit some inflammation as well. So like, I would say that the two biggies, if I had to choose to, is deal with the diet, deal with the gut, because you tackle a lot in that process. And then we have a number of really awesome supplements that can help to kind of fine tune and deal with that environment and deal with the hormonal cascade. If we're looking at, high systemic, whole system androgens, there's things that we can do to help lower that. If we're looking at the lean type where it's just local, again, there are other versions of that are only going to work at the level of those places without tanking your overall like testosterone, leaving you with like no libido, no motivation, no energy, just a blah. And so again, having the know-how of which one helps us from the treatment perspective. But those are some of the biggest, most meaningful ways. And then there's also the fancy extras, which is that like making sure that we're managing stress, making sure that we're managing sleep, that people are moving their bodies, right? Like the foundational things that we always come back to that are going to be important for most people. But when we're dealing with the big important ones, again, diet, gut, are going to be king supplements are next. And then we've got all of the extras to make sure that things are in the right place.
Yeah. And I hear all the time these days, people are like, listen, I did inositol, I did berberine, I did NAC, and I didn't get better. And vitamin D, right? Those are 4 supplements that you will find a lot of research on. You will find a lot of RCTs, which is a registered clinical trial, that show that those are effective in PCOS. And people are not RCTs. And so if you go on a combination, one or a combination of those supplements, and they help you and they help some symptoms but not others, it's because you're not an RCT. So within that, you are going to have a unique dysfunction within your gut that needs unique herbs to manage. You are going to potentially have liver issues that are preventing you from clearing insulin, that are preventing, yeah, Michelle's like, you just said liver. I'm not going to say bile because Michelle will just implode over there. She'll just be like, too much joy. But there is that component that you need to manage, right? You might have high levels of androgens that require those to be lowered with herbs in order to move forward. So with all of the excess amount of information we have these days, people will go on 2 or 3 supplements that they've seen from specific RCTs or specific TikTok studies, because those are a thing these days. And
Science.
I know, right? And they will not feel better and feel like then there's no other option. Like that's all there is for PCOS. So I must be the exception. I must be the anomaly. I must be the person this doesn't work for. And it's like I could think of 6 other systems in the body that we could manage that are very individual to the person. So I just wanted to point that out because I think that's happening a lot more in today's day and age with people being like, okay, well, I tried that and it didn't work. And that might be because you didn't get the right dosage. That might be because you don't have the right doctor. That might be because someone took the best available research and tried to apply it to you as opposed to tried to find what you need and help to gather research to support what your body needs. There's 2 different approaches, and I've been trying to articulate that a lot better, but I think that's like the best way I could articulate it. There's a lot of people right now that are taking research and trying to apply it to people as opposed to looking at a person and finding the most evidence-based way to get that whole person. And they're 2 completely different methods of evidence-informed or evidence-based medicine. I feel very strongly that the latter is more effective, but it's really, I think it's an important conversation to have.
Well, and at the end of the day, we want to be using tools that tackle a number of things, but with like, it's using one hammer for multiple nails, right? Like it's trying to tackle as many things with as few supplements. There it goes again. With as few supplements as possible.
Made sense, though. I like that one.
But it's true. You get the visual. But at the end of the day, I think people also sometimes get overwhelmed with they're like, oh, well, this is so much or it's so complicated. And there are a number of ways in which we can approach this that's going to tackle all of your things that isn't that complicated. So making sure that you're getting a tailored approach to you, to your history. And like, there's like diagnosis in the details, right? Like we just get so much appreciation in people's history. And so having the luxury of time to be able to go through those things, to be able to like integrate previous labs and current labs and see where gaps are is just so crucial in making sure that people are getting custom plans that actually work for them.
So what about Ozempic babies? This is a conversation that's also come up a lot. And there's a lot of women who went on Ozempic with PCOS who got pregnant. So what's going on there? Walk me through that.
Well, again, like if we're talking about that in the context of PCOS, if we have insulin resistance and like that's causing anovulation and you can't get pregnant, then just by virtue of, again, like from a fertility perspective, when people are ovulating, like the PCOS infertility is done. Like that is the issue. You can have compounding reasons for why that's still not happening. If you have PCOS, your PCOS is managed. You unfortunately can win the genetic lottery and have some other stuff going on. But that aside, that once that PCOS is managed and you're ovulating, you're fertile, like from that perspective, assuming that's the only issue at play. And so, yeah, with Ozempic, like again, if we're managing that insulin resistance, it's going to have an impact there.
Yeah. And it's so funny because I get asked this question a lot in the socials, in my DMs and all those things. And people are like, okay, well, is Ozempic a fertility medication? And I'm like, no. Ozempic is a medication that is one way of lowering your insulin, reducing insulin resistance. It does so through the gut, right? So it is helping to manage hormones that become dysfunctional due to gut bacterial issues, a history of yo dieting. Mix that with a little bit of liver and a little bit of aging, and Bob's your uncle, we have an issue that is solved by a medication. So it's not an issue to use the medication whatsoever. But the conversation of Ozempic being a fertility medication tells me that, yes, 75% of people are insulin resistant. And so if you're insulin resistant, and even if you're insulin resistant and ovulating, that high level of insulin, those high levels of free fatty acids that Dr. Michelle talked about earlier, that can be toxic to an embryo. So the management of the insulin is a huge piece to anyone's symptoms, I would argue, because I love insulin. But especially in this conversation of management of PCOS in your 30s, because it's going to take care of the acne. It's going to help with the brain fog. It's going to help with the cravings. It's going to help with the weight. It's going to help you kick out
With the
smecks
hair,
of your ovaries,
yeah,
right? Like the hair
the
growth,
hair
it
loss.
does all the things.
Yeah, the hair loss, the skin tags, like all of it. Yeah, the melasma, like, because again, like it's a growth thing. So, like, if we have growth issues, if you have like heavy, crappy bleeds, like if there's just kind of insulin is just so foundational. If you have a problem, insulin probably has something to do with it most of the time. Like,
Yeah. Yeah. And like, that's facts, right? Like science facts.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada. But don't worry, if you're in another province, still reach out, get added to the wait list as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
So I would love to transition this conversation into the importance of managing PCOS in community, because this is something we love to do at the clinic. It's something that's so important to us because women that are dealing with a lot of these symptoms feel very isolated. Their confidence can get hit. They can struggle to believe that they can have a full quality life. They can struggle to believe that they can get better. And so when those things happen in conditions like PCOS and weight loss resistance and endo and menopause and all of these other spaces where people really want to come together, be inspired in a group, we try to create those spaces. So walk me through the importance of that, why you love doing that, and then what we have coming up in terms of some of the group work.
yeah, group work is like life-changing. So, I mean, I personally have indulged in some group work recently, and there's something so healing and validating just about hearing other people's experiences where you're like, I'm not alone, I'm not crazy, this isn't in my head. And like the sisterhood of that in and of itself, I feel like is already helpful. But the other part with group work, so what we're alluding to is we're going to be rolling out a 6-week group program in the new year to really help people with their PCOS, to help get weight under control, reduce like adult onset acne. If fertility is a goal of yours, that can be a thing. If fertility is not a goal of yours, totally all good too. We can also teach you how to have regular cycles and feel good in your body and how not to conceive in that period of time, because we thought.
Oh my gosh, I am so glad you said that. The number of oopsie babies in our PCOS patients is exceptionally high because they have never used protection. They have never been consistent because they assume it's not the case. We get 2 months into treatment and they're 911ing us saying, excuse me, like I don't have my period for a very different reason. So I am so glad you brought that up. Oh my gosh, yes.
Yeah, well, and it's a conversation that I have when people are like not using contraception, don't want any more kids. I'm like, you get more fertile with care. Like, I just need to make that perfectly clear. So you may want to figure that out. And so anyways, we'll navigate that too, but from both lenses of if you're trying to and if you're not trying to, because knowing is you just flip a switch. It's just you do different actions in that window of time. But nonetheless, that's what that looks like. And so we're really going to be supporting people through making the changes that they need to in a group setting where you're getting individual treatment plans that are still tailored to you, to your blood work, that we're going to be running labs within that so we can make sure that you have the right assessment, the right diagnosis, that you understand, but also that you're getting the support, the camaraderie, the tips and tricks from others and from us in terms of how to actually make these changes. Because I won't BS it, that it can be hard to change some of these things and it's hard to feel like crap. So I'm like, let's, we'll pick our hard, but we'll do it in a place where you're super well supported, that emotionally we're going to make sure that things are manageable, digestible, and like able to be integrated so that you can actually see a sustained change. But we're really going to be laying the foundation for people to feel better, period, is really what we're looking to do, and to do it in the form of community. And one of the other really cool benefits of group work is that it gets to be more accessible. And truthfully, I feel like it's a better bang for your buck in a lot of ways because you're getting so much from your peers. You're still getting that individualized care. It's round. So anyways, that's going to be rolling out in the new year.
And you also that frequency, right? I was talking to someone today, and Michelle and I have the luxury of having very busy schedules. And that is a beautiful thing in a lot of ways, meaning we get to help a lot of people. And it's a challenging thing in that if you wanted to see one of us weekly, it's nearly impossible to do that, right? Like if you want support in your journey and you're like, no, I need accountability. I need regular check-ins. This is how I function the best, is with those regular check-ins, regular support, regular tips, regular tricks. Then this group assessment, right? This group treatment allows the opportunity for you to still get assessments, right? At the time of this recording, insurance companies are still accepting that as a very accurate form of treatment. And to be honest, they probably are quite happy because it is more inexpensive. But you can use your insurance to do that, to come in a group, to meet every week, to be building so much momentum over the whole course of the program with community. And so it's not just within the context of PCOS that we're running these programs. Like this is a huge part of Advanced Women's Health, and how we're moving and how we're growing is to be able to provide these experiences because one, we do surveys. We know you guys love them. Anyone who goes through them loves them. And two, because this is how people get results. We have treatment plans that work. I am very confident to say that. You know what I mean? We see over 1,000 patients a month now, right, in Ontario. And so we see a lot of people, and those people get better if they do it. And if they do it is the part of the conversation that I'm so curious about and will continue to stay very curious about in 2025, is because I believe that's within my control as the owner. So what can I do to create community? What can I do to have follow-up? What can we do to offer other coaching and support for people in a way that is cost-effective, in a way that is supportive, but in a way that helps someone to achieve their goals? Because there is nothing more heartbreaking to me, not one single thing that is more heartbreaking than having someone in front of me and I know the protocol and I see the success for them. You know what I mean? I'm like, I have done this before. Like, you're going to get better. And seeing them again a year later and them saying, I didn't have the support to action it, to get the results. And so now I'm back. I feel like a failure. I feel like I failed myself again. I feel like I failed you, which is never true, by the way. You guys never fail us, right? But now there's all of this mental, emotional baggage that's going along with it as well. And to me, that's a failure of the system, not the person. That's acknowledging that we are meant to get healthy in community. We are meant to do everything in community. That is why I started Advanced Women's Health. That is why the clinic has grown so quickly, right? That is why we have the best doctors, because I can choose with every position I have. There's like 20 people that might apply, right? I can choose the best of the best. That's because of community, right? It's because we get to hang out. It's because we support each other. That's how we get better. That's how you guys deserve to get better too. And that's a very big part of what we will be offering. So anyways, I just went on a huge tangent. You guys can tell I'm passionate about it, but we are going to have our PCOS course and a variety of other ones that are going to be available for everyone. And I'm so excited. Obviously, we have registration information in the show notes. And we are also going to be, we alluded to it, but we're also going to be doing an option for you guys to download our least common or our less common PCOS supplements. So that outside of berberine and acne and inositol and all those types of things, if you guys want to know what else is out there and what's important, then we have the download information for that in the show notes as well so that you get supported. But anyways, I just went on a ramble. So anything you would like to wrap up with there?
No, just thank you. And I'm like, this is the best. I'm like, it's super cool to get to work in a space that's so collaborative, that sees the need for how to do treatment in a way that actually gets people better. And where I feel like the patients are lucky, us as practitioners are lucky, and like, I'm ready to like hit the road now.
Awesome. Well, thank you everyone so much for listening. Definitely check out the show notes for all of our group programs and information. Definitely DM myself or Dr. Michelle, send us an email if you want more information. But like I said, a lot of that's going to be in the show notes. And if you want to know what the heck were those supplements they were talking about, we have that opt-in option for you as well. So a beautiful day. We appreciate you. We appreciate your ears. We hope you had some fun listening, and we'll talk to you all soon.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.